As we're kicking off the journal club, the sort of topic that I've chosen is something that's pretty basic. So it's just really a paper looking at caesarean section, elective caesarean sections. It's called Prospect, and it's an update on the guidelines that were produced in 2014. And I thought it was just helpful because it's something that we all do quite a lot on a regular basis. Well, sorry, apologies for those that aren't sort of anaesthetically bound, but it helps to kind of check that we are doing and taking an evidence-based approach to basic things, I think. So this is the Prospect paper that was produced, these are the summaries that was produced in 2014, and they essentially sort of gave it guidelines for what analgesics you would use sort of pre and post-op. And one of the things which I was sort of quite surprised about was that they were recommending gabapentinoids at that point, so pre-op, even though I'd never seen that in my practice. They also talked about tap blocks, local infiltration, which we do, and touched on the surgical technique that we don't really have any sort of input into that, but it's helpful kind of to know which surgical technique is better for post-op pain relief. Post-operatively, regular analgesics like paracetamol and ibuprofen, etc. So this was a systematic review looking at the same kind of areas that they did in 2014, and they basically said, well, we feel that there are quite a few things that have changed since 2014, mainly things like, tap blocks or the sort of post-op analgesic side of things, and just make sure that we're on the right track in terms of what we're prescribing regularly. So if you have a C-section, and the post-op pain isn't managed properly, it has quite a lot of repercussions, as you might imagine, for the woman and baby. It's shown to reduce the maternal bonding experience, and therefore that has a knock-on effect on breastfeeding. And we've got the lowest breastfeeding rates in Europe at the moment. That's not because women don't want to. I think it's just that the support isn't there. And we're sort of at the very point of delivery, we can make a difference to how their experience is in the first 24 hours, which is really, really key and really important.
Presumably that's not just from C-sections, though. That's just from lots of things.
Yeah, lots of things. There are multiple factors, but one of the things I think is that we have quite a high sort of operative or forceps delivery rate. Yeah. And if they've got poor pain control post-operatively, then that's going to have a massive, massive impact. So if their pain is well controlled, obviously patient satisfaction is much higher, and it just has a knock-on effect for the whole sort of first few weeks, really, to months. So it's often undertreated, and that's not necessarily to do with the fact that it's not prescribed. It's more the sort of communication side of things. A lot of women have fears that it will be transferred to the baby, even though midwives and anaesthetists and obstetricians will tell them it's fine. But that's helpful for us to know, I think, just to reiterate, I've prescribed you Ormor, it won't have any effect. Like, it's absolutely safe to take. It won't affect the baby. You must take, you will need to have it. It's quite a sore, the severity of a C-section is underestimated.
Hello. Hello. None of you on call?
Yeah, so Brindley and Hamish on call.
Okay, and they're in fine.
Yeah, exactly. So they wanted to look at the new techniques and see if they were effective. So Quadratus lumborum blocks, slow release, sort of pump, a bomb releasing local anaesthetic, and then the non-pharmacological techniques. There's a shift to lower the amount of opioids we're putting in spinals and see if that's important and has a significant effect, and also the buzzword enhanced recovery. So as with the previous systematic review, Prospect in 2014, they looked at mainly randomised controlled trials, and the dates were from May 2014 to October 2020. The the websites, those are the search engines that they use, Medline and Base and Cochrane, and then primary outcome measure was post-op pain scores. So they also looked at recovery outcomes, the amount of opioid that they used, and any adverse effects from that. Those that were excluded, so they weren't looking at emergency theatre or any unplanned deliveries, and any GA sections as well. So they're very specific, very sort of small group, just elective sections.
It's a shame they don't look at
Yeah.
GA sections.
Yeah,
Those are the
yeah.
ones where we
It's quite
struggle
important.
most.
Exactly right. Yeah, yeah. So that would be helpful. So there were 145 studies included, 126 were randomized controlled trials, and 19 systematic reviews. So it seems to be quite high quality evidence from this. So the results, I mean, this is not groundbreaking results really, but it's just, again, just to reiterate what we're doing is evidence-based. So essentially, looking at the non-opioid side of things, there was no difference in prescribing paracetamol pre-op as well as post-op. So essentially, you don't need to preload them with paracetamol. So one study said that a rectal paracetamol was superior, but that wasn't backed up by the other studies. So if you gave IV paracetamol in one study, they showed that their amount of opioid that they took was less, but it didn't actually, affect overall pain scores. Regular NSAIDs, so good evidence from a meta-analysis, reduced pain scores, decreased the amount of morphine that they were taking, and also reduced the side effects, which is not surprising. So has anyone used Gabapentinoids?
Yeah.
Or have you? Or
Yeah,
whereabouts?
Not in obstetrics.
No.
They use them in for people who had post-oral puncture headaches. It's part of the evidence for them.
Okay,
So
well that's interesting.
It's standard in St. Mike's now.
Oh, is it?
So whoever said that, could you say it a bit louder? I couldn't hear.
Sorry. Yeah. If in St. Mike's, if you have post-oral puncture headache, that their part of their protocol is giving gabapentin. So I think you give. I have to check the dose now. Is it 300? 300.
I wouldn't know,
Yeah,
but yes, but
yeah.
that's interesting. Sort of a regular gabapentin pill.
It's 300 QDS for 7 days.
QDS.
Yeah, or 100. Yes, I think it's quite a lot. It's more than you expect.
I think they. Yeah.
Well,
They normally go for 300 TDS
Yeah.
as your end.
I think it might. I have to check. It might be 100. Actually, I think it's 100 QDS. Yeah, increasing it as required.
Yeah.
But yeah, that's one of the bits that they've got evidence for. And then they also give caffeine as well for puncture headache.
The evidence for that is slim, isn't it? So,
The caffeine,
yeah,
as well as simple analgesia.
Yeah. Okay. Well, that's interesting. So they did look at gabapentinoids in quite a few of the studies, well, 4 RCTs and meta-analyses. Unfortunately, there's no evidence that it had a significant benefit. But I think in case by case, it may be helpful. Essentially, yeah. I mean, think about it, but it's not in the sort of routine guidelines for it.
Just one question.
Yeah, sure.
When you had the sort of 4 RCTs and the meta-analysis saying no significant benefits, and then the systematic review saying significant benefits, of those 2 separate categories, do we know which one has more weight behind it?
No.
Shouldn't be different than spectrum.
Sure. So I'll go through at the end how they break it down. But I think essentially they haven't given all of the data and the charts that you get with meta-analysis. They haven't published it in the Prospect trial. But I assume that you could write to them and to say, give me more evidence or delve deeper. But yes, it essentially they've said it's not weighted enough to give.
The side effects of
It's quite
sedation,
significant, aren't they?
dizziness.
Yeah.
When you're a new mum, I just don't know.
And you're tired anyway. I'm not sure that would be a good idea.
Yeah, I think part of the reason for giving it for the post-oral puncture headaches is that they're pretty
function,
anyway.
yeah.
So you're laid flat anyway.
Yeah.
Yes, and persuading them to take it as well. I mean, it's quite a hardcore. It seems like quite a heavy drug, doesn't it? For if you're trying to be sort of purist. So as with most sort of major abdominal surgery, lidocaine has been mooted. As with sort of GI surgery, they've used it, haven't they? But there are quite a few there are quite a few studies that looked at if it would be helpful to add a bolus of IV lidocaine, or add it to the PCA, and also use ketamine post-delivery. Essentially, there's no evidence for either of those. And my thoughts about ketamine, again, would be that it's also a very strange drug to be given to someone who's yeah, when you're sort of.
I also think with the lidocaine, you've got the additional problem that you have to give it post-op, because if you're giving it before the baby was out, then you could potentially be giving, because you've got a difference.
Oh yeah, sorry, yeah, this is post-op. I should have said. Yeah,
I mean, I think that's probably another reason why, if it's not giving you a huge amount of benefit, you're just adding another risk into potentially something that you shouldn't do.
Yeah. And this must have been from the States, because sufentanil and dexmedetomidine PCA. That's it's also slightly costly, isn't it? But, they said it did. I think the basic. Let's get another elective C-section first, and then go for that. So again, this is not evidence for any improvement really significantly. So this is one thing that I definitely don't do, but they have recommended, which is interesting. So you give IV dexamethasone. That leads to at kind of the end of the C-section. So better pain scores, better analgesic effect of what you have given, namely in your spinal, and reduced opioid consumption post-op, and reduced need for any antibiotics. So that is something that they have recommended. Does anyone do that?
No, that's really interesting. I wonder if there is, because quite a few women have had steroids for other reasons.
Yes,
I wonder if they're better.
Yeah. So that's definitely an improvement. I will reach for the Dex rather than the ondansetron if they're.
Would you give
vomiting.
it the GDM?
No. So you have to be cautious. No, because obviously the paper says caution with diabetes, but I think the risk benefit I probably do no, because then their sugars will go crazy, won't they? So there was a paper that looked at different opioids and if they had a difference. Essentially, no. So intrathecal morphine. This was just looking at the dose of what we insert. So at the moment we're giving 150 mics. So that's my impression. Essentially, they looked at, this is an interesting point for me, because they're looking at low versus high. So does it make any difference if you give 50 mics to 100 versus high? And essentially they say, no, it doesn't. And you're better off giving a lower dose because you have fewer side effects. So, pruritus, etc., respiratory depression. So that is, I would thought, a take-home point for me. They also looked at putting intrathecal addition, so clonidine or Dextor, which is if anyone doesn't know, Dextor is similar to clonidine, it's just a bit more fancy and expensive. Magnesium, midazolam, ketamine, and anaesthetics, and there were sort of anecdotally possible, increased analgesic effects, but the side effects outweighed benefits. The one study I thought was also interesting, and I've had heard this point before, the speed of injecting the local anaesthetic and opioid is quite important. So it has an influence on longevity and effectiveness of your block. So if you inject in quickly, that is better. Now, whether the height of the block as well,
I think also that kind of probably makes more sense if you're using something like fentanyl rather than morphine.
Yeah.
There's so much more lipid soluble that if you're giving it faster, you might be able to get up higher than if you give it slowly if you're using something like morphine.
Sure. So yes. Okay. This is looking at the local and the regional analgesia. So wound infiltration, after the operation, either by the surgeon or the anaesthetist, that was found to reduce pain scores, rescue analgesia, and if you add ketorolac or magnesium and Dextor, it reduces the pain scores as well. But later on, they say this is not routinely to be done. So looking at the rectus sheath blocks, essentially they're talking about the TAP blocks, and this is, I'll go back, Quadratus lumborum blocks. Do you want me to talk through the difference between the two? Would that be helpful for those that don't encounter them very often? So rectus sheath blocks are essentially injecting local anaesthetic in between the internal oblique and transverse fascialis. Is that right? Yeah. So I'll go to, this is the sort of more schematic view, and then where you put the ultrasound probe, and where the local anaesthetic goes, with that blue line there. And this is a really helpful block if you haven't done a spinal. So for a GA section, it's really commonly done. But the study was looking at if it would be helpful to do with a spinal as well. So is there any evidence that that improves your pain scores? You know, so I have had one of the obstetricians ask me if they want me to put in a tap, well, they want them to put in a tap block when the patient had a spinal, and I said no. But actually looking at this paper, it tells me if that's the right thing or not. So this is looking at, so 5 studies looked at the tap block versus the placebo or no tap block at all. So it says that there is an improvement in pain relief, patient satisfaction, reduction in use of rescue analgesia, and it doesn't matter if the surgeon or the anaesthetist does it. But the important point at the bottom is that a tap block versus spinal, as in if you give a tap block on top of giving a spinal, there's no real benefit, no additional benefit, I should say. So I wouldn't bother doing it.
That's really interesting.
Yeah.
Now it's asked me.
Do they do it? Are they?
The surgeons are routinely putting in tap blocks.
Okay.
You've done the spine.
Even if you've done a spinal.
Yeah, you just have to, because they ask you, because the only reason they ask is in case you've done an epidural top up, in which case obviously
Because
one of
they
that
can't
volume
do
is
it.
local.
Yeah.
But if they are routinely doing tap blocks with spinals, that's really interesting.
Just that interesting.
Well,
I always learned that a tap box, you're going to get better if you go posterior, but pretty much everyone seems to do a tap block. You've got a probe here laterally, and you're injecting. Your needles going in.
When the surgeons are doing it, they're doing it.
They're doing it direct.
Directly.
It's just in terms of if you're doing ultrasound guided.
That's
That's how I've done it before. But I've always learned that it's better to be posterior, but you're not really doing that by doing it that way.
No.
Unless you're getting them to like lean onto one side, or you're pushing them one side, it's really difficult to actually get kind of going posterior.
I think it's a good technique for us to learn, isn't it? But if you've got a surgeon directly looking at where you can inject in the local, I always think that that's probably a bit superior, unless you're quite experienced in them. So Quadratus lumborum block, I haven't ever done one, and I had to kind of look up where it went and what the technique is. So there you're injecting sort of near to the Quadratus lumborum muscle, and targeting the thoracolumbar nerves at that level. And that's sort of the schematic drawing of it. So sort of anterior, posterior, and that's essentially where you're going in to get the local around. So it's more of a sort of posterior approach, and I wonder if that the meta-analysis that looked at TAP versus Quadratus lumborum found that they were all as equally superior as one another. So you'd happy to do TAP or Quadratus lumborum or local and wound infiltration if you haven't done a spinal. So that's an important technique.
So it's spinal or any of the 3, and they all have the same effect.
Yeah. No, sorry. Spinal is superior.
Spinal superior.
Yeah, but if you haven't done a spinal,
Haven't done anything,
then do one of those. Exactly. And that's looking at elective sections, but obviously I think this is more translating towards GA section, and I know this doesn't look at the GA section, but I think it would be reasonable to say, right, that would be a good technique to use.
Well, I'm probably being really silly. Is it in the absence spinal?
Sorry, no.
Just morphine.
Morphine, sorry.
Opioid,
Yeah, it's the opioid.
Yeah.
Sorry, yeah, because you'd always do spinal, sorry. But it's if you haven't put any opioid. I don't know why you wouldn't. But, So these are the recommendations. So they say a slightly lower dose of morphine. Dimorphine is the same as what we have used, so 300 mics. Epidural, similar to what we have used. So this is when you put the opioid in at the end. So 2 to 3 milligrams of morphine, 2 to 3 milligrams of dimorphine. Sorry, that's right. And then after delivery, paracetamol, NSAIDs, and IV Dex. So this is what I've just sort of reiterated. If you're not using opioids in the spinal, then you can use either a single injection of local anaesthetic, continuous wound infusion, and or the fascial plane blocks. regular paracetamol, NSAIDs, regular or rescue opioids, so dihydrocodeine and oromorph. And then they said they recommend using TENS as an analgesic adjunct, and that has evidence that it improves post-op pain scores. And also they've mentioned listening to music, distraction. Fair enough. Yeah, that was really good, isn't it? The surgical technique is also important for post-op pain. I hadn't heard of, has anyone else heard of the Joel Cohen incision? So, sorry, can you see that? It's very tiny. There is a, yeah. So a slightly higher than the Pfannenstiel and straighter, I guess I wanted the best word. That's supposed to be better for post-op pain relief. And also, you know, the abdominal binders, that's really helpful for women to sort of not put pressure on the scar, I think. And non-closure with peritoneum, not that I'm, yeah. So again, we don't have any influence on that, do we? So those are the summaries that I can send to you if you're interested of what they would recommend on the paper.
Yes, please.
Yes, will do. And this is the sort of justification for all of the other things that I talked about, why there wasn't enough evidence, essentially saying lack of procedure specific evidence. I think that the criticisms of this systematic review, and it's not really their fault, but all of the papers are very heterogeneous. So essentially, you know, there were high quality evidence, but look at the way that they were carried out, it was so different. So that it was quite difficult for them to kind of, with the weird and the wonderful kind of techniques, it was difficult for them to say, oh yes, okay, definitely do this always. Again, the authors have noted that, yeah, it's not that helpful that they haven't included emergency C-sections or GA, because that's really the situations that the probably patient is more likely to have post-op pain, isn't it? And in the elective section, it's very controlled, and you don't tend to have as many issues in my sort of experience. As I've said, the limitations, the studies were all very different in methodology. So the majority, what they're saying is the majority of studies, they didn't sort of benchmark against the ideal regimen. It was just, yeah, the comparison was very different. Does that make sense?
Did they tell you how much they put in the spirals? It'd be interesting to know.
Of local anaesthetics?
No,
I didn't.
There's quite a lot of variation.
There is. Do you think that would affect post-op pain? I wonder.
Potentially,
yeah.
Like if you were doing a lower dose, you may well have enough for the surgery, but then you might have higher post-op pain scores, or you might find that you have more complications, which they probably haven't included, like hypotension.
Sure. Which will undoubtedly affect your pain scores, won't it? Because
I take your point, because the opiate, the reason we do the opiate component, it does increase the quality drop, but it's actually for the post-op pain.
It's for the pain relief, isn't it? Yeah.
That's where most probably.
Yeah. Okay.
They had no medical conditions.
Exactly right. So those I would say those are probably my two main criticisms of the review, in that they're looking at sort of the ideal patients, aren't they? So elective sections, no severe comorbidities, which is just not realistic in our patient cohort. And they're also not measuring. They're measuring post-op pain scores, but the authors have said it would be better to have a more comprehensive review of the outcome of the patient. So mobility, you know, satisfaction, sort of patient-centered. So looking at the future studies would be helpful. It's the bottom three that I think it would be most helpful: time to ambulation, hospital stay, and chronic pain or chronic opioid consumption. So any thoughts? Helpful? I mean, it is sort of teaching grandma to suck eggs, isn't it, that paper? But I thought there were a few points there that I will definitely remember. Like, yeah, the IV Dex is a helpful take-home point for me.
Are you going to change the amount of morphine you get?
So I don't use morphine. I'm a fentanyl person. Yeah, because it's just keep it simple for me. for my simple brain. But I think if I were to use morphine, I probably, it's difficult, isn't it? Because it does affect longevity. And
so that's why I use
longevity of post-op pain relief or longevity of the block in surgery. That's what my concern would be. Yeah. So the prospect said that there's no difference, but I agree. I'd be cautious. But fentanyl, again, I haven't noticed any sort of, from the pain score point of view. It was more the length of block, and again, anecdotally, putting in a slightly higher amount of fentanyl seems to make the block last a bit longer, which here seems to be a bit more important. Not to sort of
How much fentanyl do you use?
So I use 25, yeah, but I used to use 15, but then putting in 25 seemed to be better. And some of the surgeons take quite a long time compared to somewhere like South and St Mike's, I'd say. Use 15, do you? Yeah, and it's fine. It's fine. There we are.
So if you're going to extrapolate that out, say your emergency section, the GA, so you've got GA, give them decks.
Yeah, definitely. Yeah.
Give a local block.
Yeah.
As well, and then all the other multimodal.
Yes, exactly. So I think it would be I think it would be frowned upon is probably the right way of putting it. It wouldn't be completely out of the realm of normal practice, but perhaps not ideal if you didn't do any kind of local infiltration for a GA section, I would say.
How happy are the surgeons giving tap blocks?
Yeah. Well, the ones that I've done, I haven't done that many.
Not all of them.
No.
There's one or two of the trainings that we do with some of the consultants who go into that.
Okay, so it's more in us.
So I think it's surgeon dependent.
Yeah.
So the practice that you specifically is that you would add IV decks, you would consider more the local reading.
So consider local, IV decks, and reduce the amount of opioid, possibly. That's up to them.
Would you give it routinely, or would you just give it in preference to non-opioids?
Yes, I think so. Yeah, that's sort of what I've come to the conclusion of, because no one else seems to be giving it here. And I might chat to a couple of the consultants and see what they feel, because definitely not in any patient with diabetes.
Yeah.
But I do end up giving ondansetron quite a lot. Maybe because I haven't been tapering the phenylephrine high enough and they're getting a bit hypotensive. But I will give ondansetron. But I would just give Dex. Yeah.
Actually.
And any questions from you guys at home?
I have one.
No, thank you very much, Jeannie. It's given me some food for thought and possibly some bits and pieces to change in my recipes.
Yeah, great. Cool.
Was
that Owen? No, it was James, wasn't it?
No, I've got one too. We are similar.
We're all the same.
You're at one.
Just talking about the Dex versus ondansetron thing. So in my practice, and I might just be being a cowboy, I don't routinely give people ondansetron until they start feeling sick and it's not related to the blood pressure. So it's usually in the context of having lots of uterotonics. My understanding of Dex is that it doesn't work quickly. And so giving them Dex instead of ondansetron isn't going to solve the pukey patient on the table there and then. It might make them feel better in an hour or two, but it's not going to help right there and then.
Although I would sort of slightly counter argue that ondansetron is sort of to make me feel better, where normally it's just because they're a bit hypotensive. That's and the side effects of the drugs.
Yeah, but there's definitely the group of people who are nauseated in the absence of hypertension when they get all the uterotonics, aren't there?
Yeah.
So
that's a really good point. You could give both, couldn't you?
I guess if you're giving the uterotonics that you know that are associated with feeling sick, so then you could just give it at the same time. So
there's definitely an argument.
You could, I think that you could argue that potentially, if you know you're going to give something like Carlofrost or something like that, or Hemabate, when you're giving that, if you give the Dex at the same time, then you can always give them more ondansetron later on.
One thing though that I was just thinking was that if the rationale for giving Dex is anti-emesis, it's a bit different from a rationale of giving it for post-op
No,
pain.
but it does help with the pain.
No, I agree with you. But if you're giving ondansetron to treat an immediate like an emetic patient, if you give Dex in addition or something, or if you give Dex for different reasons, if you get Dex earlier for post-op pain, and it also happens to have an antiemetic effect. I'm not explaining.
No, you are, but no one really knows how Dex works from an antiemetic, at least his point of view. So it may work or it may.
Yeah.
So I think with anything where you're acting on the basis of the paper,
Yeah.
the way I look at it is you can look at the paper and then you can look at the department in which you're working, and it's generally a good idea to get the consensus of the consultant body. So I find if you're kind of acting outside what the OBS lead or the obstetric consultants are doing, then you probably have to have quite a high justification. So the reason why I'm sort of slightly sitting on the fence with the Dex is because yes, it's recommended, but I haven't seen anyone else use it. So I think I would discuss it with Julian and see what their thoughts are, and be sort of guided by them as well. Because one of the consultants was sort of saying to me, I know this is a systematic review and it's a highly thought of systematic review, but there is a lot of fudging data in medical research, which is a controversial thing to say, but
They do just to try to
for sure.
because
And
they want to have a desired outcome.
yeah,
They want to-
yeah, and I want to practice in an evidence-based way, but I don't want to just be a slave to evidence-based. Does that make sense? So I think essentially give the ondansetron, as Owen says, that's a really good point. It works faster for antiemetic properties, and then you can consider giving Dex as well for that purpose. It will help because you will feel a bit grotty after the section anyway, and then it will potentially help with post-op analgesic and duration of block and duration of opioids and reduce pain scores. Yeah, is that okay, guys? At home.
Yeah, thank you very much.
Oh, are you what are you up to? Both pre-nights or?
I'm pre-night and Owen is too.
I might stop. I'm going to stop recording the session now, but we'll keep the teams moving on.
See you